let's finish off this section going back to points that Suresh, you mentioned about the role of checkpoint inhibitors in early stage disease and where we're heading. Just to go back a couple of points here. We've got a couple of different data sets coming out sooner rather than later. The Anvil study, as you mentioned, the LCMC is doing a neoadjuvant trial with atezolizumab. BMS is doing a neoadjuvant trial with Nivo. Is this where the field is heading? Do you think this is where we're going to be applying these drugs? And do we need a different endpoint for these neoadjuvant studies rather than overall survival, a surrogate endpoint that may be quicker to achieve?
So the exciting data with immune checkpoint inhibition in stage 4, now in unresectable stage 3B, clearly lead us to a possible scenario where these drugs can be used to cure patients even more effectively than what we're doing right now. So that's the excitement about integration of checkpoint inhibition in early stage disease. And if what we've seen so far holds true, I think we should be able to cure more patients with these agents. And the questions would be, what markers can we use to select those patients who benefit? So that's why the Anvil, which is the ECOG-ACRIN-led NCTN trial, and some of the other pharma-led trials will all answer the question. The neoadjuvant approach is also very exciting. We have not shown in lung cancer so far that the neoadjuvant approach is better than the adjuvant approach in any trial. Yeah. So if we can take a group of patients, induce major pathological or complete pathological responses with relatively brief duration of immune checkpoint inhibition, either by itself or with chemo or as combination of checkpoint inhibitors, I think that'll be a major advance in our ability to improve outcomes for our patients. With regards to endpoints, I think for curative settings, survival will continue to be the main endpoint we look at. We can certainly use some intermediate endpoints to get a signal for our early phase clinical trials to see if a regimen looks promising enough or not. And that's where the major pathological response comes in. Complete pathological response is another such endpoint. But ultimately, our conviction to use this across the patient population would depend on impact on survival.
Yeah. Any other points regarding the neoadjuvant/adjuvant approach? I think the data is obviously, we still need to wait and see. I think some of these surrogate endpoints may be important, but overall survival is still what we look for in these trials.
Well, two things. Well, the neoadjuvant approach certainly has great scientific merits, but we have to, of course, make sure we don't compromise in any way patient care. But if history is any guide here, all of the therapies in lung cancer always have had better activity as they've been moved up. Chemotherapy in the metastatic setting, moved to the earlier stage, chemoradiation, adjuvant therapy. So the earlier we can get, if these drugs really work, the earlier we can get them to patients, the better. So I think that's going to be the trend, and we'll do it through clinical trials.
Naiyer, you and I were having a conversation before the panelists about how earlier stage disease may be more immunogenic, or immune therapies may work in earlier stage better than they work in advanced stage. Do you think that is going to bear out?
It's possible. I mean, we know from the metastatic disease setting, we commonly are starting to see more failures in one location, one area of metastasis. It could be a subclone, which is ultimately resistant, but if it's for earlier stage disease, maybe there's less tumor heterogeneity, a smaller subclone fraction, maybe you can do a better job of eradicating cancer.
Yeah, the whole idea of immunoprevention now has come to pass. There are just a couple of Stanford for Cancer Dream Teams that were funded, and they're looking at early disease, and they're looking at MHC and antigen presentation in these tumors. So it might be that we start using someday immunotherapy in pre-neoplastic lesions, or in patients that have smoking-induced damage who have stopped smoking, for example.
The future is rich.
Absolutely.
For these drugs.